Welcome, ladies and gentlemen. My name is Ajit George. I'm a consultant in diabetes and endocrinology. I'm also an honorary senior lecturer at the University of Manchester. This session is going to be about diabetes. Let's start off by trying to define what diabetes is. Diabetes is the sustained inability of the body to maintain blood glucose in the normal range. Why is this important? Because normally blood sugars are kept tightly in range to avoid complications. So elevated blood sugars are also associated with a number of metabolic derangements and an increased risk of diabetes-related complications. Diabetes can be due to reduced insulin secretion, as you would see in a person with type 1 diabetes who's got damage to the islet cells of the pancreas, or it can be due to increased insulin requirements or a combination of the two, as would be seen in a person with type 2 diabetes. The WHO has given us some definitions on how to diagnose diabetes, and these are based on numbers. You can use HbA1c, which is a damaged hemoglobin product. When you expose hemoglobin to blood glucose, hemoglobin is irreversibly converted into advanced glycation end product, and that's called glycated hemoglobin. So normal is less than 5.7% or 40 millimoles per mole. Impaired glucose tolerance is anywhere between 40 to 47, and greater than 48 millimoles per mole is diabetes. We can also use blood glucose levels. Fasting blood glucose in the normal range should be less than 6. Some people say 5.6 millimoles per liter. 2 hours after a 75 gram glucose tolerance test, you should have blood glucose less than 7.8. That would be normal. And you can see that there is a progression to impaired glucose tolerance based on fasting blood glucose and to our postprandial blood glucose, and also diabetes based on fasting and postprandial. Now, if the person is symptomatic with hyperglycemia, a single test is sufficient. But if the person is asymptomatic, you have to repeat the test. Also, it's worthwhile mentioning that this is in the non-pregnant state. Diabetes in pregnancy has got a slightly different set of numbers. Moving on to insulin resistance and the metabolic syndrome, we talked about increased insulin requirements. So to put it very simply, if person A, who is insulin sensitive, has a slice of bread, now a slice of bread has about 20 grams of carbohydrates, we have to, if they are insulin sensitive, they will require 2 units of insulin to deal with the carbohydrates in that slice of bread. However, a person with insulin resistance might require 4 units. So 2 things come to light there. Number 1, it takes more time for glucose to be disposed of in a person with insulin resistance. Number 2, the pancreatic beta cell has to work much harder to secrete more insulin to dispose glucose from that slice of bread. Now, insulin secretion has got 2 phases. There's the first phase of insulin secretion, as you can see on the graph on the right. And then there is a sustained second phase of insulin secretion. Perhaps one of the first changes that occurs in people with type 2 diabetes, where the beta cell is constantly overproducing insulin, is that there is fasting hyperinsulinemia, and consequently there's almost no first phase secretion of insulin. This is because the beta cell is completely out of insulin stores. Now, in the islet in the pancreas, there is a complex interplay between the beta cells which secrete insulin, alpha cells that secrete glucagon, and a few paracrine cells which regulate alpha and beta cells. With constant rise in insulin resistance, there is increased beta cell workload, and actually beta cell mass starts to decline. Insulin secretion falls, and at some point the person progresses through normal glucose tolerance test to impaired glucose tolerance test, and finally full-blown type 2 diabetes mellitus. What about type 1 diabetes? Type 1 diabetes is thought to be due to an immune attack, and we know this because we can detect certain antibodies in the blood which give us an indication of the autoimmune attack. It might be a viral attack, and there might be molecular mimicry whereby the proteins on the surface of the beta cell might look like viral protein, and thereby triggers an immune attack. It might be environmental, it might be genetic, there may be several factors that contribute. Autoimmune attack can be of two types. There's the fast rapid presentation to diabetic ketoacidosis in the younger age group, but also in the older age group you can have a slow burning type 2 type picture where the person goes through a phase where there's impaired glucose tolerance, type 2 diabetes mellitus like picture, and finally on to complete destruction of the beta cell and type 1 diabetes. This is called latent autoimmune diabetes in adults, and is often seen in the older age group with positive antibodies and a complete lack of C-peptide, which is a marker for endogenous insulin secretion. We'll come back to that in a later slide. What is insulin resistance? Insulin resistance, as we defined before, is greater demand of insulin to dispose glucose. But why do we need insulin resistance? Why is it that, evolved creatures as humans are, why hasn't it disappeared from the genetic pool? The problem there is that there are times when the body requires insulin resistance. Okay, so the first would be puberty. Puberty is a time when lateral growth or abdominal obesity is not required. What you require is vertical growth, bone and muscle growth. Now, if insulin is working well, then you would store glucose into fat cells. But the body secretes a number of different hormones, including growth hormone, testosterone, estrogen. All these hormones induce a state of insulin resistance, bypassing and glucose and other energy-rich sources bypass the liver and storage sites and go on to muscle and bone, where it is used to increase vertical growth. The second is pregnancy. Now, if we think about it, pregnancy is a state where the baby grows in the mother, and the baby is entirely dependent on the mother for energy. If the mother's metabolic machinery is working well, then the mother will store all that glucose. However, the placenta secretes a hormone into the maternal circulation that induces insulin resistance, preventing the mother from storing energy and diverting it into the fetus. Stress is another time when you are diverting energy away from stores into the blood, and that is for, let's say you have an infection, you need energy for the immune cells, repair all these processes, and energy is diverted by stress hormones that induce insulin resistance. What are the types of diabetes? The common types are type 1 and type 2 diabetes. Type 2 diabetes by far forms about 90 to 95% of all diagnosed diabetes mellitus. Type 1 diabetes is about 5%. There are a few other causes, including maturity onset diabetes of the young, or MODY as it is. This is important because it is a single gene defect that has led on to diabetes. Diagnosis of MODY is important because the treatment is slightly different. It can be misdiagnosed as type 2 diabetes. However, there are a number of other types of diabetes, mainly type 1 and type 2 diabetes. How do we differentiate between type 1 and type 2 diabetes? It might look obvious, but there are some factors that clinically help us differentiate. When I say clinically, that immediately means that there is no single acid or gold standard test to help us differentiate between type 1 and type 2 diabetes. We use a number of clinical features to help us make our diagnosis. Going on to the next slide, here are a few bullet points, and I'd like you to take a moment here to pause and think about how you might try to make a diagnosis of type 2 versus type 1 diabetes in the patient sitting in front of you. We can see age is a factor that certainly helps. Younger people by and large tend to have type 1 diabetes, but again, like we mentioned, LADA can occur, type 1 diabetes can occur in older adults. And I am seeing people who are younger and younger with type 2 diabetes, possibly due to increase in body weight. Weight helps us differentiate. Usually people with type 1 diabetes tend to be quite normal body weight, whereas type 2 diabetes tend to be overweight. The distribution of fat tends to be predominantly abdominal obesity in type 2 diabetes. It is much more common in Afro-Caribbeans and Southeast Asians. Family history is stronger in type 2 diabetes. If you have macro or microvascular disease at the time of diagnosis, it is likely to be type 2 diabetes. And the reason for this is that type 2 diabetes has got a latent period, a quiet period, where you go through a process from normal glycemic tolerance to impaired glucose tolerance to type 2 diabetes mellitus, and it can be several years before the diagnosis is made. If you have a history of hospitalization, particularly for diabetic ketoacidosis, it's likely to be type 1. Similar to that is that if you need to go on to insulin within a year of diagnosis, that's also likely to be type 1 diabetes. Hypertension and lipid abnormalities are more common with type 2. Symptoms and weight loss tend to be more common with type 1, predominantly because of the speed at which type 1 diabetes comes about. C-peptide is a marker of endogenous insulin secretion. It is part of the pro-insulin molecule, which is cleaved to form mature insulin, and that is only seen in endogenous insulin secretion. So if a person comes with insulin overdose, C-peptide will be absent. GAD antibodies, islet cell antibodies are all seen in type 1 diabetes. But looking at the number of factors that we need, it's fair to say that no single criteria will help us differentiate between the two. Why are we interested about diabetes? Is it just a number on the screen? Usually, blood sugars don't cause much symptoms unless you go hypoglycemic or you have severe hyperglycemia. What we are really worried about are the diabetes, chronic diabetes complications. These can be microvascular complications, as in retinopathy, nephropathy, and neuropathy. They can be macrovascular complications, the big blood vessels, cerebrovascular accident, myocardial infarction, peripheral vascular disease. However, all parts of the body, they're supplied with small and large blood vessels. So this is a picture of an advanced kidney disease, the glomerulus showing eosinophilic nodules. These are Kimmel-Steele-Wilson nodules due to the deposition of amyloid. You can see foot ulcerations in the pressure areas Clearly, the person does not have much sensation on his feet due to nerve damage. And in the eyes, you can see a number of dot and blot hemorrhages. These are fairly advanced complications of diabetes and exactly what we're trying to avoid in a person with diabetes. Why does it matter? Because diabetes affects life expectancy. If we have diabetes on its own, it takes away about 6 years from a person's life. When you have diabetes and cardiovascular disease, that takes away 12 years. Diabetic kidney disease is also associated usually with cardiovascular disease, and that is a loss of 16 years of life. Not only is there reduction in life expectancy, the amount of time that you spend with morbidity is also increased. A person with diabetic kidney disease may be in and out of the hospital for dialysis for several years. What can we do about it? Since the publication of the UK PDS trial table shown here, as well as the DCCT trial follow-up studies, it has clearly, without a shadow of doubt, demonstrated that you can make a difference if you control diabetes intensely. One must be careful that it's not a one-size-fits-all, so we do need to tailor our treatment and our targets according to individuals. That's the end of the lecture. Thank you for your attention. Please contact me if you have any questions.